My guest for this episode is Chris Cornett, an associate professor of orthopedics at the University of Nebraska Medical Center. He's a career changer and my brother. We're going to talk about how he made his decision to become a spine surgeon at Nebraska Medicine. He's vice chair of clinical services in the Department of Orthopedics, the medical director of outpatient physical and occupational therapy, and co-medical director of the comprehensive spine program. This is Invincible Career, and I'm Larry Cornett. So before we dive into the interview, I want to talk about the treasure hunt this week. If you haven't heard of this before, basically every week I'm asking a question or I'll have a challenge, and there will be a gift for the winner. Sometimes I ask that in my newsletter at newsletter.invinciblecareer.com. Sometimes it's in the actual email that I send out for that newsletter. So be a subscriber if you want a chance to win. And then, as I said, sometimes I'm going to ask the question or offer the challenge in this podcast. And I'm doing that this week in this episode. So I'll provide some clues and the question a little bit later in this episode. And I'll explain how you can answer that question, where to answer it, so that you can win the prize, which is an ebook this week. It's going to be a Kindle book, not a Kindle. A book. But I will be providing more details about what the book is and give you a chance to win. Welcome to the show, Chris. Thanks for making time today.
Thanks for having me.
So let's start with telling the audience a little bit more about who you are and what you're doing right now.
So my name's Chris Cornett. I'm from Western Nebraska originally. I went to undergraduate school at Lincoln, majored in biology, had some interest in pre-health. Initially thought I would have a strong interest to do physical therapy or some type of rehab.
Mm-hmm.
Had interest in sports. I was interested in activity. I've always been pretty interested in health. And at the time, when you're young, I didn't think I wanted to devote all the time to medical school and some of the different medical trainings based on the length of the tracks, and was already had some considerations about, starting a family and things like that by the end of college. So anyway, I applied to graduate school and attended physical therapy school at the University of Nebraska Medical Center in Omaha and did a 3-year master's degree there. And, interestingly, while I was in grad school, I had some exposure to some of the different fields in medicine. And I think I was a little naive as to how broad medicine was and,
sure.
The different options for jobs. And once I kind of had some shadowing or some exposure with that, it's really probably for the first time in my life, I got really excited about my career and potential career, or just opportunities for work or development. And I think that's one of those things where you don't really know that you haven't had that until you haven't.
That's
so,
right.
So it kind of really was kind of an aha moment. I mean, I literally remember coming home, waking my wife up, probably much to her dismay at like 11 p.m. and just running through all the potential options in medicine, whether that's cardiac surgery, neonatology, radio, all the different things. And it just seemed like a really big open box, and I was very excited about it. So I kind of just almost had an aha moment and decided, hey, I need to switch gears, which is a little tough to do in the middle of grad school.
Yeah.
But nonetheless, to her credit, she was hugely supportive of it and almost said, hey, if you feel this way, you can't not do this. And so I finished grad school, literally went to like a Barnes and Noble and bought an MCAT book because I hadn't taken chemistry in 3-4 years. I had done well in college, luckily, and I had all the prerequisites, so I didn't have any problems that way. But took the MCAT, finished my grad school degree, applied to med school. So I graduated in May, started med school in August. So
I remember that.
So I went through 7 straight years there, and then went through medical school. And then in medical school, being a little bit more savvy, I cast a pretty broad net, really looked at
Mm-hmm.
everything,
Yeah.
and then honed in on orthopedics. And within orthopedics, I thought I had an interest in spine, but I didn't commit to that yet. And again, just tried to set myself up for success and for keeping my options open. And then matched in orthopedics at the University of Wisconsin in Madison. So I went there for 5 years, looked at all areas of orthopedics, studied all areas. Again, kind of honed in on spine, decided I wanted to do spine surgery, and then went to Pittsburgh Medical Center after I left Wisconsin for a complex spine fellowship, and then came back to the University of Nebraska Medical Center as a staff physician and teaching in the med school 10 years ago. So now I work at UNMC and the hospital associated with that is Nebraska Medicine. And we teach residents, teach med students. I teach pain fellows, physiatry residents, and then also we do some research. I have some administrative duties. Currently, I'm vice chair of clinical services for the Department of Orthopedics. I'm an associate professor in the university. I'm medical director for outpatient physical therapy for Nebraska Medicine, and then also medical director for the comprehensive spine program. And then primarily what I do is clinical work. So I do, I'm a adult and pediatric, but mainly adult spine surgeon.
Mm-hmm.
We take level 1 trauma call. I treat tumors, fractures, disc herniations, back pain, scoliosis. I mean, you name it. So I do surgeries, have clinics, see patients, all those things. So that's kind of a nutshell of what I do now.
So you keep busy.
Yeah.
So end to end, how long were you in kind of school and training and residency before you actually were doing surgery? How long was that whole process?
Well, it was a little bit extended for me, obviously, right?
Yeah.
And then, not unlike you, I worked through college too.
Yeah.
So I think in undergrad, I spent about 4.5 years in undergrad. So since I had an extra semester, you blew that second semester. So I think it's right around 17 years if you add it all up.
Holy crap!
After high school.
Wow.
Yeah.
Wow. I mean, that's
pretty
huge
much 17
commitment.
years contiguous. Yeah.
Yeah. So I don't know if people understand.
It is a huge commitment.
I don't think people understand. They're like, I want to be a doctor, I want to be a surgeon, but I don't know if they fully understand the entire process of getting that education. I guess it depends on what you choose too, right? If you're going to be a GP, it's probably quite different.
Yeah, you'd shave off 3 or 4 years, doing that. So if you hadn't gone, for instance, someone that didn't go to grad school like I did. So if I hadn't gone to grad school and I'd have went straight into medical school and then I would have became a GP or a pediatrician or an ER doc, I functionally would have gotten done there 6 or 7 years sooner.
Okay.
So it's quite a bit of difference.
That's huge. So, I mean, one of the questions that comes up, and I remember talking with a guy who's been on a different podcast, Benjamin. So we were talking about the cost of medical school and loan options and loan repayment options. And we've all seen kind of Northern Exposure where he got shipped off to Sicily, Alaska to repay his medical school expenses. What are the options that are available for students that are looking at some way to make this manageable?
There are options out there. I was fortunate in that through undergrad, I had a tuition scholarship.
Mm-hmm.
And then I actually had they call it a Regents in Nebraska. I had a Regents through grad school and through medical school. Right. So actually I paid no tuition at all, but I still had cost of living and even in medical school, I had a child. So there still are other expenses. And depending on where you go to medical school, the cost is astronomically different. I mean, it could be 5-fold increased depending on where you go. And so, a medical degree at Duke is not the same cost as a medical degree at UNMC. And people don't always talk about that. And then you just have to value, you have to look at what you value or what you want, because you got to realize it's not like with a certain degree, you're guaranteed a 5-fold increased income.
Exactly.
Depending on where you go to school, right? But I would say there's a lot of options. Most of the options stem in primary care because that's where, our society is, there's a lot of shortages there. And that's where they're trying to encourage people to go into primary care, and then specifically primary care in underserved areas. So either
Oh, right. Yeah.
a rural area or a community that's underserved
Mm-hmm.
in an urban area. And so a lot of times, if you'll commit to going back to places like that, there's a lot of loan repayment options. So usually that money is not up front. There are some programs up front, like in Nebraska. I actually originally signed up for a rural program and won a scholarship that was
Mm-hmm.
quite a bit of money. But then within 6 months, I actually gave it all back because I decided,
Right.
I once I'd sort of honed down and I guess not made a mistake, but maybe didn't think globally enough. I decided I wasn't going to do that again. So I always wanted to keep my options open. So then when I honed down just for a financial reason, I decided to give it back. And it was a good decision for me because I think I would have perhaps switched careers again.
Right.
So
Sure.
I think, money is important, but the loans are there. And typically, if you go into certain fields that aren't going to get those paybacks, a lot of times your income's enough where you'll be able to pay your money back.
Sure.
If you go into other fields such as primary care or GP, there's a lot of options to get that paid back. Now, if you pick a particular city or a particular community and say, I really want to live and work here, you may not have that option. But if you're open to going to some other places or, kind of seeing what's out there, there's options to pay it back. But it's certainly it's a commitment. I mean, the expenses are enough. It's unless you're fortunate and have a lot of background money or you have somebody helping you, it's unrealistic to think you're done and you pay everything off in a year or two. That's not very common.
Yeah, exactly. So I mean, going to graduate school to study for physical therapy added years kind of to the whole process, but do you feel that studying to be a physical therapist made you a better surgeon later?
Yeah, it's a great question. I think it did. Could I have the same job? I could. Would I have the same breadth of knowledge or maybe the same appreciation for things? I don't think so.
Okay.
And I think that's one of the things that sometimes people don't realize in medicine. There might be an analogous field where they study just one area and people say, well, how's that much different? I mean, part of the benefit of a medical training is that you see a little bit of everything for years and years and years and years. So like for me, when I came back here, I'm a brand new spine surgeon, whatever, 10, 11 years ago, but I've been doing medical training and healthcare for like 15 years at that point, or 16 years. So it's a little different than somebody that's just starting a job and has never seen this before. And so, I think it did help. It's given me appreciation for a lot of the non-surgical aspects of things. And then we spend a lot of our time ordering therapy. And so when I order therapy, I don't just order therapy. I kind of know what they can really offer or not offer someone.
That's a good point.
And, help them. And there's times I'm like, therapy's probably not going to do you much good. I mean, I know what they can do for them or can't do. So it's helpful for sure.
Do you feel like you work better with PTs given that you understand that world?
Absolutely.
Okay.
Yep. Okay. I do. And I think, I also think there's a lot of, surprisingly, this is something I maybe hadn't guessed. I have a lot of patients that see me that actually say, oh, I saw you were a therapist, and they actually like that.
Oh, interesting. Okay.
Because I think they think it means that maybe I have another slant and I'm not maybe just looking to operate on them. If there's other options, I'll have that in my toolbox too. So I hadn't anticipated that, but it seems like in general, my patients view it positively.
That's a good thing. Okay. So how did you make the choice to go into being an orthopedic surgeon? Because like you said, you had this huge box of options kind of in front of you that excited you. How did you decide, oh, I want to do this versus cardiology or neurology, or, there's so many things you could have done.
Right. Yeah, it's a great question, and I mean, ultimately, it's like a lot of things we do in life. It's a little bit of a leap of faith. You kind of go with the gut instinct and what you like, and then you hash out all these other decisions like training, potential income, work-life balance, and naively going into medical school, you kind of think, hey, I'm going to have exposure to everything. I'm going to look at everything, and then I'll
try it
really
all.
know what I'm going to do. it really doesn't work like that. You don't have time to train and everything. So
Sure.
you spend a lot of time training on, natural or normal anatomy, normal physiology, pathology, all the different areas of the body and systems. But then when you go and do like rotations, you can't do a rotation through every area.
That's true.
I mean, most people aren't doing fertility medicine rotation, for
Right.
instance. And a
Right.
lot of those docs, for instance, probably go through OBGYN.
Sure.
And you might find an individual that would really not want to be an OBGYN, but they might love to be a fertility doc.
Sure.
But you got to go through that 4 or 5 years of residency,
Mm-hmm.
subspecialize, and then what you do. So like I went through general orthopedics and I do spine. I only do spine surgery. I don't
Right.
treat anything
Right.
else in orthopedics. But for 5 years, of my residency, I did all orthopedics.
Yeah, I remember you were
And
doing
so
hip replacements and stuff. Yeah. Yeah.
yeah, so you do everything. And so it's really hard because you have to really look ahead and not just say, what do I want to do? But you have to say, I got to realize I might spend the next 7 years working a lot, not doing what my final goal is. So it's
Right.
real long-term planning, which is always a little challenging, right? But so I looked at things that I liked. I looked at what felt good for me, and then you make your best guess. And then the other thing I did is I'm a big fan in training and education and trying to
Mm-hmm.
keep your options open. So I looked at, for instance, with orthopedics, there's so many different fields, joint replacements, tumor, trauma,
Mm-hmm.
hand surgery,
Mm-hmm.
foot surgery, and I liked a lot of those areas, meaning if I couldn't do spine, I had a lot of different options I could do that I'd probably be okay with.
Sure.
Whereas maybe some other fields, if I went into general surgery, maybe I would be okay doing cardiothoracic, but I really didn't want to do, bowel surgery, or for
Mm-hmm.
instance. And
Mm-hmm.
so I kind of try to pick an area that I liked most of the things within it. So I had
Okay.
different
That makes sense.
options.
Yeah.
And then you try to get an exposure in areas you're interested in. And then ultimately, though, it's a little bit of a leap of faith.
Yeah. So the other thing I think people don't probably realize, because maybe they just see it glorified on television and movies, is how demanding the job is. So I mean, and I know there's been times it seems like you're just working round the clock and a lot of fatigue and a lot of long hours. I mean, what is the job like, kind of day in and day out?
I would say, there's big differences between, your training and not training. And so when you're in your training, you're working a lot of hours, a lot of call, and it's all kind of mandatory and forced on you.
Mm-hmm.
And you don't have any control over your schedule. So you don't have a lot of autonomy.
Okay.
So it's definitely not like you finish, for my field as a surgeon, it's not like you finish training and now I'm a staff surgeon and all of a sudden my hours are really good.
Right.
If you add up the hours, I work a lot of hours. The big difference is my autonomy increases significantly.
Sure.
And so depending on your personality, for me, autonomy is one of my big key things.
Mm-hmm.
And so
Mm-hmm.
I kind of recognized early that I almost value autonomy over everything else. And so even over income, over work hours.
Oh, yeah, we have that in common. I didn't know that.
Yeah.
Yeah, me too.
Yeah. And I think a lot of people value autonomy, but I guess it's more like, what are you willing to give up?
That's
for
right.
It,
That's right.
And so,
yeah.
So typically the more autonomy you have, the more you have to work because you're invested in it personally. Right. And I mean, that's why you have autonomy. But so for instance, I took some time off over the holidays, but time off for me means I didn't schedule clinics, I didn't schedule surgeries, but I still took some call.
Right.
and
Sure. Yeah.
and almost every day I'm taking, and you do the same, I'm taking, multiple emails,
Oh yeah.
texts, and to the point where I might even have to call a patient and talk them through something, or
Mm-hmm.
just because these are my patients, I've operated on them, and there's really nobody else that can kind of triage the problems they're having other than me. I've got assistants and I've got a good nurse practitioner and great nurse managers and all these people, but ultimately it has to bounce through me.
Right.
And so I would say that's one of the things about my job, not to digress too much, is that my hours are variable, but I'm never totally off.
Sure.
So
yeah.
I don't come home
that.
and shut off. Yeah. I might come home and get a call. I might not,
Sure,
but I might
sure.
get a call, or I might have to run in the hospital and I don't even know I'm going to.
Right.
So
right.
But I'm an early guy. I like to exercise early in the morning. So I get up at 4, I exercise. I usually go to work anywhere between 6 and 7. I go to clinic or surgery all day. I have meetings in between, during, and then I might get home anywhere between 3 to 8 p.m. It's really
Right. That's
variable
true.
depending on the day.
Hmm.
So if I can get done and I have to get somewhere, I'll get done. But the biggest thing is it's always a question mark. So for instance, if my wife says, "Hey, there's a game, do you want to ride together?" I'm always like, maybe.
Yeah, you
if,
don't know.
if I get done in time, I will. If I don't get done in time, I can't. And so
Right.
I think that uncertainty part can be a little challenging, certainly for you, but even more so for your significant other or your family.
Yeah, that's true. That's true. Yeah, like you said, it's a trade-off. You could have a job that is literally 9 to 5. You clock in, clock out, very predictable, but the upside is less. Usually, it's just unfortunately kind of
Right.
what comes with it.
Right. It's just the way it goes. And I have a lot of friends that are like that, or when they're off on the weekend, they're off,
Right.
and so
Yeah.
um,
Yeah.
I might be off, but it's like there's things that could come up, and it just can happen.
Right. You have to be ready for that call or text.
Yeah.
So you've probably seen a lot of changes over the last kind of 10 to 15 years. And so I'm kind of a question of what have you seen already change in the field of medicine and surgery? And recently a lot, but kind of the last 10 to 15 years, and where do you see it all going in the next kind of 10 to 20 years?
Yeah, it's interesting. So obviously, the last 2 years have been really a big change for all of us in healthcare, but everyone outside of healthcare, and it's kind of fascinating because I think it's one facet of healthcare, but the whole world's been exposed to that facet of
Right,
healthcare,
right.
like
Yeah, we're all learning about it.
infection,
Yeah.
right, infectious disease and mitigation of things and all these things, but I think the continued push in healthcare, which is true of a lot of areas, is less and less and less. Nobody's giving you more for less anymore, and that's
Sure.
and
Yeah.
that's true in everything. Um, the amount of money they pay for a given procedure is a fraction of what it was, 15 years ago. And I don't know if
Hmm.
everybody's even aware of that. Now, what you pay or what your insurance bill shows might be higher,
Sure.
but the amount reimbursed back to the provider is actually quite a bit less over the years. So
Oh, is
it is
that
one of
right?
the,
Wow. Okay.
yeah, it's one of the few areas where, the amount of payment, for instance, for a hip replacement you get now is a fraction of what it was many years ago,
That's crazy. I
which
didn't know
people
that.
probably don't know
No, I
that,
didn't know that.
but it's true. Now they've gotten more efficient, and you could argue maybe it was too much years ago, but
Hmm.
anyway, it's usually what happens over time through government and insurance changes are, people generally are trying to pay a little bit more for the same thing over time. And they're trying to incentivize quality of care, which is a good thing, efficiency.
Sure. Yeah.
And so where it used to be years ago, you might say, I'm going to do this surgery and you have pain and I sign you up and just do it and the insurance
Hmm.
pays for it. No questions asked. That's rare now.
Okay.
So now the insurance and a lot of these things are driven by, good things. They aren't all bad. But now your insurance will look at it and say, is this seem reasonable? Have they
Mm.
tried other things? So maybe you'd had to have failed physical therapy,
Oh, I
or
see. Okay.
you can't say I've had pain for a day, boom, I get this. In my world of orthopedics, because it's more elective things. Traumas are different, or appendicitis, that's different. But elective things, say a knee replacement, you can't come in and say my knee hurts. They
Right.
look at it, you got knee arthritis, boom, you get a knee replacement the next week. A
Mm.
lot of times they want to show you've tried other things. Maybe your weight's too high. They focus on BMI,
Mm-hmm.
smoking status. Have you had physical therapy? Have you tried anti-inflammatories? And then has your pain persisted past a period of time? And then it's reasonable. And if it's not
Right.
reasonable, those things might get denied, or you have to do an appeal. So I think us interfacing with the insurance companies and trying to get things accomplished has only increased over the years.
Yeah.
The margins for hospitals, they have to work a little harder, to keep their margins where they want, because their reimbursements aren't what they used to be. And in general, there's been this kind of global push. Everybody hears about this in the news about, how do we cover everybody insurance wise? And do we gradually drift towards more of a social medicine, or do we get parts of that, or how do we balance that with individual choice
That's right.
and all these
It's a
things?
huge question. Yeah.
Yeah.
So, I mean, technology has definitely been something that's changed a lot since you first started on this path and are where you are now. I wonder how much more do you think telemedicine and being able to do kind of remote work with patients is going to continue to increase? Because you already talked about the fact that you're texting and emailing with people, which wouldn't have happened 15, 20 years ago, right? So
Right.
it's interesting, and I wonder how much more this will increase, or how much even the pandemic has accelerated the need for it, for specialization that doesn't necessarily require being physically together in an office.
Yeah, it's funny. We actually talk about this a lot, how the pandemic has what's a couple of things. One is a lot of these things were available before the pandemic, but we didn't use them. And so, like a lot of things with technology, if you don't use them, they're futzy and you don't like them, and then you think they don't work well,
Right.
so you don't use them.
Yeah,
So,
yeah.
but if somebody, but if you get forced to do Zoom, after so many Zoom calls, you're like, this isn't so bad. And then
Exactly,
after a while longer, you're
exactly.
like, oh, this is kind of nice. I don't have to like run across campus to a building. I can
Right,
just stop
or
where I'm at
drive
and
an
do a
hour and a
Zoom
half
call
to
on my
work.
phone.
Yeah, yeah.
Right. And so things like that have been huge. I mean, we did all in-person conferences. They're early. People come from across town,
Mhm.
and then you have to go back to different hospitals. And so a lot of our conferences have been Zoom.
Right.
And so telemedicine, we've done telemedicine in my clinic. Some of my partners do it a lot. And there's a lot of visits that telemedicine are totally appropriate for.
Mhm,
And
mhm.
so I think those things are only going to increase. The technology's been crazy, just even some of the surgical stuff, with some of the navigation or different things I do in surgery are way different than what I would have done, I mean, even 10 years ago.
Right.
Um, but the patient interactions, and now there's apps that follow you along after surgery, and they'll send the patient a reminder that, hey, did you do your stretching today? Did you do this? And so I think it's limitless. I often kind of think back. I'm sure you remember we discussed this, I think, when I was in college.
Mm.
So that would have been like in the early 90s, mid 90s. And we had talked about electronic health records at that
Yeah,
time.
yeah.
And that almost really predated some of the really monster EMR systems that are
Right.
out today, that
Yeah.
everybody has electronic records,
Yeah.
But
Now it's a
I
billion-dollar
actually
business.
trained,
Yeah.
and it's crazy, but I actually trained when we still walked around and wrote notes in the chart, like
Right.
handwritten notes. And that was still part of my training. I'm probably one of the last era of people that have done that, but it's,
Funny,
or
huh?
my
Yeah.
generation is. But yeah, it's changed dramatically.
So back to the treasure hunt. This week, I'm offering a Kindle book as a gift, and it's a book by Cal Newport. You may have heard me talk about Cal Newport before. I've really enjoyed his books, and this one is So Good They Can't Ignore You: Why Skills Trump Passion in the Quest for Work You Love. And I like this. I think it runs a little contrary to the follow your passion advice, but provides some real tangible advice that you can use to develop a career that I think you would love and you'd be successful with. So I want you to go to newsletter.invinciblecareer.com. There's going to be a post, it's a treasure hunt post, and that's where you can answer the question about what is the gift this week? What is this ebook? So you can answer So Good They Can't Ignore You: Why Skills Trump Passion in the Quest for Work You Love by Cal Newport. How much do you think robotic surgery is going to continue to advance and be a part of what's going on with your practice? Because I'm seeing it already with other types of surgery. I mean, I think spine surgery is a little different, but does it start to introduce itself?
Yeah, that's a great question. A short answer would be I'm not 100% sure. The long answer is there are certain areas that I think robotics have been, and I'm told from my colleagues that robotics are never going to get replaced.
Mm-hmm,
They're the way to
mm-hmm.
go. So, for instance, like some of the complex prostate surgeries, some of these things, I think just on the angles and how minimally invasive it can be,
Right,
it can do things that we can't do without robotics.
right,
So
right.
I'm sure the first time somebody did a laparoscopic, that's where you poke a
Yeah.
hole and
Oh, I
stick a
had that done.
scope through the
I'm
belly.
quite aware.
Yeah, for your appendix.
That's right.
The first time people did those, I'm sure a lot of people were like, "These are not going to take over. It's not as good as seeing, and it's actually better."
Right. Exactly.
Um,
Yeah.
Spine's a little different. So for my field in spine, I use navigation. So, and there's different ways to do navigation, but navigation meaning, you know, we patients on the table, we run a scan,
Mm-hmm.
and then we have reference frames that reference a localizer to where the spine is. And then in surgery, I can literally put my pointer on a piece of bone and look at the screen and see it like a 3D CT scan. And so I can put screws exactly where I
That's
want and things like that.
fantastic. Wow.
Those are neat, and they work really well. They're not absolutely necessary, but I think it's
Mm-hmm.
for certain cases they're better, and I use it a lot. Robotics in spine's a little different because it's a combination of the navigation and then also what do you have the robot do? Usually the robot's functionally like some type of mechanized arm.
Sure.
You know,
Yeah. Yeah.
it doesn't look like a Rocky Four robot, but but so you get the navigation part, but then instead of you hand screwing the screw in, it might put the screw in or drill
Right.
or,
Right.
and so I have a little bit of uneasiness with that in spine because there's still a lot of what I do where I want tactile feedback.
Mm-hmm.
I want to
Mm-hmm.
see that if I slightly come through a bone, I don't want to hit a nerve.
Yeah.
And
Yeah.
and ultimately, when you're trusting technology, there's going to be occasional oops factors, and
Sure.
I
Sure.
haven't been able to come to grips with if we can allow that, or two, the other thing that happens in medicine is you might say the robot puts it in a degree better, but your degrees of freedom on what's good is 5 degrees. So maybe
Right.
it's a degree better, but it doesn't actually change outcomes. And if that's the case, then
Mm.
you got to try to rationalize the cost. And so there's certainly robotics in spine already. We have a robot at our institution. I'm a little more hesitant to jump into robotic spine. I'm not quite sure where that's going to go. The other thing is, like robotic and joint replacement, for instance, I mean,
Mm.
that's been
Mm-hmm.
around actually 15, maybe 20 years longer. It still hasn't universally taken over. So sometimes there are some people use it, some don't. So clearly it hasn't, changed everything.
Right.
So there are some fields where it's really taken over and some fields I don't think it will.
Okay. Okay. Well, before we wrap up, I was wondering if there's any advice you would give to, a younger person who's listening or a career changer, like Benjamin's a career changer who worked in tech for many years. And he's like, you know what? I want to do something that has more meaning and purpose. And so he's going into, the medical field. So what advice would you give to somebody who's starting down this path or wants to switch into this path, things that they should think about?
I guess the biggest thing I would say is don't be afraid to do it.
Hmm.
Um,
Hmm.
I had a lot of comments over the years about, gosh, you've been in training so long, you're doing this and that.
Yeah. Yeah.
The problem is, I mean, unless somebody else has that figured out, we've only got one life. And so if you feel like you have a different calling or there's something you can do that will fulfill you more
Hmm.
or you can contribute more to, this world or society,
Right.
I don't think life is long enough to not do that. I mean,
Mm.
and the other thing is, no matter how long it seems, it doesn't seem as long as sitting and doing something you don't like for your whole life. so,
There you go.
so
There you go. Yep.
I came back and started here in my mid 30s, but you're then going to work the next 30 years doing what you like, or I could
Right.
do 40 years doing something I don't like. So I'd rather spend 30
Yeah.
years doing what
Yeah.
I like.
Exactly.
And the training isn't, I mean, the training's interesting too. So, I mean, I think it's just, you have to be willing, to sacrifice some things. But the other thing is, and we all experience this, 2 hours of doing something you like is better than a half hour you don't like. So even though you're
Hmm.
spending time and you're working a lot, it doesn't feel like that. So
That's
like I
true.
work a lot, but I love my job. And ultimately, if I can take care of somebody and they do well and they have a good outcome and they're happy and I can see them improve. I mean, it's more rewarding than, anything else I do as
Yeah.
far as jobs I've had in the past. So I think, don't undersell doing what you want to do, being mentally stimulated and feeling that you have made an impact and that you have some autonomy. These are big global concepts that you can't get with every job.
That's so true.
So if you have the capacity to do things, I say go for it,
I love it. Good advice. Good advice. Well, that's a good note to end on. Chris, thanks for coming on the show. This has been very helpful, I think, for a lot of folks, and the questions that came in that we addressed. I think there are a lot of tough decisions, but like you said, it's better to do something that you feel has meaning and purpose. And I agree. When you're doing work you love, it doesn't feel the same as work that you hate. It's completely different.
Absolutely.
Completely different.
Yeah.
All right. Well, thanks again, and enjoy the rest of your day.
Yeah, thanks for having me.
Thanks for listening. I hope you enjoyed this episode, and if you would like to follow upcoming releases of the show, please subscribe. And as always, I appreciate your ratings and reviews. Thank you. If you would like to learn more about Invincible Career and the podcast, you can visit invinciblecareer.com. Until next time, I wish you the best of luck in becoming an opportunity magnet for the best things in life.